Hello everyone. Our today's topic is Pediatric CNS disorder and its management. Introduction. Neurological conditions are the problem with the brain, spinal cord, or peripheral nerves. Children may experience difficulties with physical functions such as mobility, strength, range of motion, balance, and coordination. This problem can also have an impact on child's development. This means that they may reach developmental milestones at a later age, and this can also impact on functions such as head control, crawling, walking, and talking. Types of neurological problems. Congenital disorder including cerebral palsy, CP-child, hydrocephalus, or spina bifida. Developmental disorder including ataxia, ADHD, attention deficit hyperactivity disorder. Dyspraxia, also known as DCD, developmental coordination disorder. Head injury, autism, epilepsy. Tumors of the brain and spinal cord, seizures, peripheral nerve injuries, disease of the spinal cord, learning difficulties. Symptoms: increase or lack of growth in head size, lack of balance and coordination, changes in activity, reflexes or movements, mobility problem, decreased muscle strength, decrease muscle tone or spasticity, changes in level of consciousness or mood, decrease range of motion, developmental delay. Seizures, muscle wasting or slurred speech, muscle rigidity or tremors. Older children may also report persistent or severe headaches, loss of feeling, and visual changes. Assessment: name, age, gender, date of birth, birth weight, birth head circumference, birth height, chief complaint, history, antenatal history, regular antenatal checkups, took iron, calcium and folic acid supplements, felt fetal movement, at which month, any history of fever, infection, etc., any other complications during pregnancy. Prenatal history: normal delivery or cesarean section, presentation, cephalic or breech, any other complication during pregnancy, did the baby cry immediately after birth? If not, after how long? Was the baby kept in NICU for any reason? Any history of fever, jaundice, seizure, any history of congenital deformity, any other complications. Postnatal history: when did the parents first notice the problem? Any history of meningitis, fever, trauma, etc. Did the parents consult the doctor? Physiotherapy advice? How's the condition progressing? Is the child better or deteriorating? Family history: father and mother's age, number of children, their age, any history of abortion or deaths, history of similar complaints in the family. Developmental history: gross motor, head control, rolling supine, to side lying, rolling supine to prone, rolling prone to supine, sitting with support, climb stairs, pull self to stand, standing with support, standing without support, walking with support, walking without support. Fine motor, voluntary grasp, reach, grasp. On observation, general. Is the children alert, drowsy, irritable, crying? Build, facial appearance, posture, supine, head in the midline or not turning to both sides, visual tracking, position of upper limb, position of hands, position of lower limb, breathing patterns. Prone, able to turn head to side in prone, able to lift head in prone, able to achieve prone on forearm. Sitting, sitting on floor or sitting on stool. Standing, position, dependent, independent. Transition, supine to side lying to prone, and supine to sitting. On examination, higher cortical function, alertness, recognizes family members, give response to play activities, follow commands, is able to tell the needs, well oriented. Cranial nerve examination. Child older than 5 years tested as in adults. Less than 5, blink response, eyes follows movement, facial symmetry while laughing or crying, motor reflex, startle reflex, gag reflex, symmetry and tone of the tongue. Sensory examination. Child older than 5, same as adults. Less than 5, check response, eyeball movement, turns head towards side of touch, etc. When touched. Check pain. Neuromuscular examination. Tone, superficial reflexes, DTR. If more than 2 years, use hammer. In less than 2, tap using your fingers. Developmental reflexes. Primitive reflexes. Spinal reflexes. Musculoskeletal examination. Range of motion. Manual muscle testing. MMT. If less than 5 years, document if movement against gravity is present or absent in the limbs. Tightness, deformity or contractures, LLD or limb girth. Investigation. X-rays, CT scan, MRI, electro-diagnostic tests. Physiotherapy management. Physiotherapy treatment will maximize the child's potential and promote physical development to reach specific goals such as crawling or walking. The treatment commonly uses exercise in conjugation with hands-on treatment to facilitate development. The treatment is very individually focused and will vary from child to child. Treatment may include balance training. Environments must be structured and tasks created in both open and closed situations to allow greatest carryover to functional life skills. Closed tasks are those whose characteristics do not change from one trial to the next. These require less information processing with practice. Open environments require more attention and information processing. Strength training. Progressive resisted exercise improves muscle performance and functional outcomes in cerebral palsy children. Closed chain v open chain. Use of TheraBand, TheraTube, springs, weight cuff, bike, stationary bike or treadmill. Aerobic, plyometric, core stability, ball, TRX, circuit training, treadmill walking, step ups, sit to stands and leg presses. Aquatic therapy. The relief of hypertonus in the spastic type of cerebral palsy is one of the major advantages of aquatic therapy. Buoyancy, viscosity, turbulence, and hydrostatic pressure are properties of water that can provide assistance or resistance to a body. Bobath neurodevelopmental therapy. This is the most commonly used therapy method in the CP worldwide. It aims to normalize muscle tone, inhibit abnormal primitive reflexes, stimulate normal movement. It uses the idea of reflex inhibitory positions to decrease spasticity and stimulation to promote the developmental of advanced postural reactions. Fine motor versus gross motor skills. Fine motor skills: stacking blocks, holding crayons and pencils, drawing pictures and writing, using scissors, brushing teeth, buttoning and zipping, brushing hair, using fingers or utensils to eat, opening lunch boxes. Gross motor skills: standing, walking, going up and down the stairs, running. Ball skills: kicking, throwing, catching, riding a bike or a scooter, setting up, climbing a ladder, rolling, getting out of bed. Bernstrom's 6 stages of recovery. First, flaccidity, no voluntary movement. Second, synergies or minimal voluntary movement. Third, synergies performed voluntarily. Fourth, some deviation from synergy. Fifth, independent or isolated movement. Sixth, individual joint movement nearly normal with minimal spasticity. Stretching, re-educating movement, Brunstrom approaches, motor relieving program, standing and quality of walking, etc. Thank you.